Welcome to the third of 4 webinars at the National Cannabis Prevention and Information Centre we'll be hosting in October and November this year. My name is Dion. I'm a research officer here in the clinical training team, and I'll be introducing you to today's presenter. I will also be moderating the question time at the end of the presentation. Please type through any questions you would like answered by today's presenter while the talk is in progress, and I'll do my best to make sure that these are addressed. Today's presentation is by Professor Steve Allsop. Professor Steve Allsop has been involved in policy, prevention and treatment research and practice, professional development and service management for almost 30 years, and he's currently working at the National Drug Research Institute. His presentation today is titled Synthetic Cannabinoids. I hope you enjoyed today's presentation. Steve, over to you.
Thanks, Leon. And as was said in the introduction there, please, if you do have questions, ask them, and at the end we'll try and cover as many as we possibly can. I should also mention that I am proudly associated with the National Cannabis Centre as well, and in that context, I do refer people to some of the excellent resources that have been produced by NCPIC on cannabis generally, but also on synthetic cannabinoids. So if there are any particular issues, there are some excellent resources that you can get from the website from NCPIC. So first question, I guess, is what are synthetic cannabinoids? Sorry, it's just, there seems to be a timing thing jumped in. What are synthetic cannabinoids? Well, basically, synthetic cannabinoid mimetics were developed to study the endocannabinoid system. And the reason for that was there was some interest amongst researchers and some companies in the possibility of developing therapeutics. The endocannabinoid system is essentially a system that we all have in our central nervous system, which affect things such as appetite and pain and so on. So over the last 30, 40 years, a number of people were involved in research. I'll mention one of those in particular later on. And in that process, developed and examined a group of cannabinoids to look at the possibility of developing therapeutic medications. Some medications were actually developed out of that research. Some of you may have heard of Sativex or dronabinol, which are medications that are used for things such as pain or nausea or appetite stimulation. But in more recent years, they were, in inverted commas, discovered by people who had an interest in marketing them for, if you like, their pleasurable effects. And these individuals, these companies, produced the products that were not intended for therapeutic effects, but really for their pleasurable effects. Most common amongst these sorry, I don't know what's happening, my slides are jumping forward. Most common amongst these in Australia was chronic, but other names are things like K2, Spice, and so on. I'll talk about some of the names later. If you look at this slide, you can see a number of things. A small packet of synthetic cannabis would cost round about, when this came out, round about $65. You can see it's small, it's 3 grams. You can see that it looks like organic cannabis, and I'll talk about how that's done in a second. The other thing that you can see about it is it doesn't look like the image that many of us might have of illegal drugs. It looks very professionally produced. So basically, what are synthetic cannabinoids? Again, it's jumping forward. Sorry about this, everybody. The most common names, there seems to be a timing crept into my slides, everybody. If the moderator can just have a look. Just wait a second, please. Okay. Sorry, can we just hold a second? Is the moderator able to fix this? My slides are jumping forward of their own volition.
I'm having a look for you now, Steve. Won't be long.
Okay, thanks. Okay, so the most common names that have been used in relation to synthetic cannabinoids are things like spice. That was a name that was used in Europe. K2 is a common name in the US, and as we've already mentioned in our region, chronic. Other names are things like voodoo, karma. They appeared round about 2004 in their current form in Europe, and were advertised at the time as meditation potpourris, or one of my favorites there, tropical car perfumes. Very often on the packaging it would say not for human consumption, despite the fact that all the other indications were that it was precisely for human consumption. They're functionally similar, same thing's happened again, sorry. They're functionally similar to THC, and again I'd refer you to there's a great nitpick bulletin on this. They bind to the same cannabinoid receptors in the brain and other organs as organic cannabis does. And they're made to look like dried cannabis by being sprayed onto dried vegetable or herbal matter, which allows it then to be, as you saw, rolled up and smoked in the same way that you might smoke organic cannabis. Whilst the packaging makes what are apparent claims about the content, so if you look at the packaging, it usually has information about what's contained in the product. When you analyze the product, there's not always a strong resemblance between what the claims on the packet are and what's actually in the synthetic cannabis. Again, we've jumped forward. Sorry about this, everyone. So if you look at the chemical structures of some different cannabinoids, I've taken this from Zavilska and Wojciech. You can see that there are some commonalities in molecular structure across the different cannabinoids, but there are also some distinguishing features. Now, one of the things there is you'll see that quite a lot of them are named JWH15, JWH203. That's actually from John W. Huffman, who was one of the researchers who was originally involved in exploring and developing a variety of different synthetic cannabinoids. And there are scores of different synthetic cannabinoids, which is a key point that I'll come back to. So what are they? They can be distinguished by the presence of pronounced variations, considerable inter and intra-batch variability, ever-changing composition. What does that quote tell us? It tells us that you don't always know what you get. The content of synthetic cannabinoids seems to change from batch to batch. So it's very hard to say that chronic that you might have bought this week will be the same as chronic that you might buy in 2 or 3 weeks' time. And that's a key point in relation to understanding the effects and understanding what the risks might be of synthetic cannabinoids. Here's another comment in relation to what might be included in European spice. And as you can see again, a broad range of product, some of which clearly will have similar effects to natural cannabinoids, other substances that are there from plant matter, other flavors to give it a sweet flavor, and a variety of preservatives. But again, this composure will change from batch to batch. So just some overarching comments. I'm very sorry, everybody, about this. I don't know what's happening with my slides, but first is that synthetic cannabinoids have only been on the market for recreational use for a very short time. As I mentioned, first came into notice in the early 2000s in Europe. That means information about the short-term harms is limited. They've not been around very long for us to get a sense of what they actually do. And in terms of long-term harms, for obvious reasons, we know even less about that. Again, from this slide, you can see a couple of things. One, there's a variety of different names and types of synthetic drugs that are out there. Secondly, they are very professionally packaged, which of course, certainly in the early days of chronic in Australia, it was marketed as a legal substance, which of course had an attraction for some people. They were also marketed in some places as a drug that wasn't tested for in drug testing. So again, if people wanted to use a cannabis-like drug, the claim was that you could use it without fear of being detected through drug testing in your workplace. And that attracted quite a lot of people as well. Again, it's jumping forward. So some, again, overarching comments. The available information we have about synthetic cannabinoids and their impact on people is limited by a number of things. Firstly, particularly in the early days when the substances came on the market, all we could do clinically was say, well, we think that the effects are probably going to be similar to organic cannabis. That was as good as information we had at the beginning. We then also rely on self-reports. So people who were interviewed or who'd completed online questionnaires, they would say, I used synthetic cannabis and this is what happened. The problem is we don't know anything about the individual, what individual risks they might have, what vulnerabilities they might have. We don't necessarily know what other drugs they might have used at the same time. And as we've seen, even if somebody says, well, I used chronic, well, one person using chronic in January might be in Perth, might be using quite a different substance from that might be used in July in Sydney. And then when we did have information from a clinical setting, the reports were often on very small samples of attendees. I'll mention later, but for example, one of the biggest studies until recently from hospital setting had a sample of 15 people. So the key point I'm making here is this is why we have had very limited information about what the risks of chronic and other synthetic cannabinoids might be. So we don't, going back, we don't always know what patients or respondents have consumed. We don't always know whether other drugs were used. We don't know what individual vulnerability exists. So it's, we need to be cautious in some of the claims that we might make about what the risks or lack of risks might be in relation to cannabinoids, synthetic cannabinoids, and we certainly don't know what the longer-term risks might be. We've no idea what the risk might be of someone using synthetic cannabinoids over a 10, 15-year period, simply because that length of time hasn't occurred yet. We may make some assumptions based on our experience with pharmacologically similar drugs, but there are limitations to how we might generalize that across. Now, having said that, we do have some information. Sorry, again, it's jumping forward. So one of the studies was reported by Winstock and Barrett. It was part of a very large global drug survey. So as you can see there, they had 15,000 participants in 2011. And nearly 20% reported that they'd used synthetic cannabis, and nearly 1,000 had done so in the last 12 months. Nearly all of the people who reported that they'd used synthetic cannabis had also used organic cannabis. And we'll come back to that point. By the way, a key issue here is, of course, this is people self-selecting into an online survey. Despite the fact that it's a large sample, we need to be cautious in generalizing it to the broader population because there may well be, one would expect, some selection bias in that sample. The sorts of things that people said the synthetic cannabis did to them was they thought it had a shorter duration of action, but it was quicker to have a peak onset of effect. Most preferred organic cannabis over synthetic cannabis. They thought that it gave better pleasure when they were intoxicated. They were more able to function when they used organic cannabis compared to synthetic cannabis. And also there seemed to be higher reports of negative effects or unwanted adverse effects, hangover effects, and greater paranoia. And then about 2% reported that they'd actually had such severe response to synthetic cannabis that they'd sought medical help after using. And the most common reasons for presenting for medical help were panic and anxiety, and for some people, paranoia and breathing difficulties. You'll see a common theme from other studies come up in relation to this. The next one is a study of Australian online consumers, and again you can see very similar effects. About a third reported using on a weekly basis, and 7% reported daily use. And the sorts of reasons people used was curiosity. They'd heard about it, they wondered what it did. For some people, the legality attracted them into it at that time. For some people, they were after the therapeutic effects. In this study, compared to another study I'll show you in a moment, a relatively small number of people reported that they'd used it to avoid a positive drug screening test. And quite a large proportion of them reported some unwanted side effects, which what might be fast or irregular heartbeat, a sense of dissociation, dizziness, paranoia, psychosis, and again, a small number reported seeking help because the consequences was for them so severe. Most of them continued to use cannabis, organic cannabis, when they were using synthetic cannabis. Some of them said it was better than or equal to organic cannabis, but sorry, I've got that wrong. Most rated synthetic cannabis favorably in comparison with cannabis, but the majority of them preferred to continue to use organic cannabis. Here's another study, leaping forward. And this was a study of people who were in substance use disorder treatment services in the US. Again, about 38% of them reported that they'd used synthetic cannabinoids in their lifetime. And again, the similar reasons, curiosity, wanting to get high, but here a very large number wanting to get high without having a positive drug test. That may reflect differences in the sampling between Barrett and Bonar et al. It may also reflect the fact that drug testing in general is far more widespread in the US. And then a similar report, I'm sorry about this jumping, it's causing me one or two. Okay, let's go there. So the sort of clinical effects that have been reported have been so similar to the effects that you might expect from synthetic cannabis: euphoria, relaxation, sedation, impact on short-term memory. I mean, if you looked at these observed clinical effects, you probably would think these are very similar to organic cannabis. But there's also been some presentations in clinics, and remember, this is where people say they've used synthetic cannabis, but what they've actually used is not always clear. So some of the clinical presentations have been for agitation, anxiety, in some cases psychosis, very fast heart rate, seizures, convulsions. Now, these are symptoms, some of these symptoms are more consistent with using amphetamine-type substances as opposed to using cannabis. So it's led some clinicians to question whether it might be related to a serotonin syndrome, which does suggest that there are some clinical consequences, at least for some people, which are different in nature to organic cannabis. So to summarize the key point that I'm making there, some of the clinical presentations are consistent with the sorts of experience that you might have with some people who have adverse reactions to organic cannabis. But there are some distinguishing features from synthetic cannabinoids which seem to more mirror the sorts of experiences that you might have with substances such as amphetamine-type stimulants. There's also been, again, another study from US National Poison Data, a sample of nearly 2,000. Again, similarity in the sorts of effects. So the key point that I'm making here is, in terms of adverse outcomes, using different sorts of research methods, whether it be online sampling, whether it be interviewing people in drug treatment services, whether it be observing what's happening in emergency departments, there seems to be some consistency on the types of adverse consequences that occur for a proportion, not all, a proportion of those affected by synthetic cannabinoids. There's also domains where we have limited knowledge. So, for example, we don't have a lot of knowledge about the impact on the workplace and driving, although there's some evidence now beginning to accumulate about driving. But one would expect that you would have similar risks from synthetic cannabis to the sorts of risks that you might have with organic cannabis. That is, we know that using these substances, you may have an increased risk of accidents in the workplace or indeed whilst driving. The potential for dependence is not clear, although there's a number of case studies that have been reported that suggest there's a similar profile of tolerance and dependence that can emerge for people who have used synthetic cannabinoids that's similar to organic cannabinoids. And some, again, small clinical case studies have reported the risk of psychotic episodes and psychotic relapse in individuals who might have already had a psychotic episode that's precipitated by heavy use of synthetic cannabinoids. Just to give you an illustration of what the case studies are alike. So this is a report by Burns and Lung and colleagues who reported that there seemed to be an association between synthetic cannabis and ischemic stroke in young adults. In both these cases, the young women, they were in their 20s, and the cases had risk factors for it. They already had risk factors for ischemic stroke, but they were otherwise young and healthy, and the concern, the clinical condition emerged within hours after they'd first used synthetic cannabis. I just provide this as an illustration of how cautious we need to be, that there are these clinical case studies emerging. They do alert us to considerations we should give in relation to the risk, but we also should add substantial caveats to some of the information. The sample is small. It's young adults who already had risk factors. The amount that the amount of risk that was added by the use of synthetic cannabis is unclear. But it certainly is something that the clinical case study tells us it's something that we should explore further. So going back, how did the law in Australia respond to synthetic cannabinoids and indeed in other parts of the world? Well, basically, scheduling and import laws have been used. And in the early stages, many states used the misuse of drugs legislation to ban the possession and sale of synthetic cannabis. So, for example, in 2011, after concern about these drugs emerged in Western Australia in the newspapers, the WA government listed 7 synthetic cannabinoids and banned them under the Poisons Act and also after changes to the Misuse of Drugs Act. What happened? Well, within 7 days, the industry that was selling synthetic cannabinoids simply produced, as you can see in this slide, a new formula. So they claimed that the new formula of chronic didn't have the 7 synthetic cannabinoids that had been banned. They just put some new ones in. And this was part of the problem. The law responded by banning them. In fact, what happened in WA was they gave 7 days notice that they were going to ban them by Friday, whatever. And of course, there were big parties that happened around the state of people using it while it was still legal. So at least in the short term, it may well have added to risk. And in the longer term, the industry simply moved. Not literally moved, but moved in terms of the content of the product. So eventually what happened in Australia was, go back, sorry about this. What eventually happened was chronic was placed, and synthetic cannabinoids were placed in Schedule 9 of the Therapeutic Goods Administration Act as part of 8 synthetic cannabinoid groups. And basically the view within Australia at the moment is that the various pieces of legislation that have been brought in means that the synthetic cannabinoids are no longer legally available, although there are still different interpretations across some of the different jurisdictions about what this means in terms of practical application, particularly at an operational police level. Because, of course, if you're an operational police officer and you see a shop that's selling a so-called legal high, how do you know what's actually in that product unless you go through the process of having it analyzed? So a lot of operational officers will still argue that there are challenges in interpretation and application of the law, but the jurisdictions will tend to tell you that it is now not a legal product, or that the products including synthetic cannabis are not legal products. Now, just a key point from my point of view, the lack of research evidence about the long and short-term harms of synthetic cannabis is sometimes perversely interpreted by some as indicating these drugs are low risk. I remember being at a presentation where somebody pointed out that from their point of view, only 2% of people in the study that they were talking about, that only 2% of them had actually ended up in an emergency department. So it was a very low risk profile. And I guess it depends on where your standards might lie. I interpreted that as a very high risk. For example, if a pharmaceutical company developed a new product and marketed it, and it was found that 2% of the consumers ended up seeking help at an emergency department, I suspect that that drug may well be withdrawn until its safety profile could be improved. So what we should more conservatively be saying about synthetic cannabis is that the safety profile of the various products has not been clearly established, and the emerging evidence indicates that there are some potential and significant acute harms, and we have very little idea about what the long-term risks would be of chronic use and chronic heavy use. We simply have very little information, direct information about what those risks might be. So that would take me to a much more conservative conclusion about what the risks of these substances are. So what does the evidence tell us? Firstly, the evidence is building, but it's still limited. You will still find very limited information about prevalence. We don't have much information about prevalence across Australia. We've got some indications from the IDRS and EDRS that are run by NDART, that's the Illicit Drug Reporting System and Ecstasy Drug Reporting System. We have some indication from the National Drug Strategy Household Survey, but it's very limited. But the evidence that's available tells us that synthetic cannabis probably doesn't have broad appeal to cannabis-naive consumers. What I mean by that is, in the samples that we've seen, it's usually people who've already tried organic cannabis who then try synthetic cannabis. But I need to be cautious about that conclusion because that might simply be a sampling effect in the studies that have been done. The other evidence leads us to conclude that with people who are already cannabis consumers, synthetic cannabis isn't a complete substitute. And I think that's particularly the case now that its legal status has changed and that, in fact, a number of companies do drug test for synthetic cannabinoids. So while some people prefer synthetic cannabis, most people prefer organic cannabis, and synthetic cannabis tends to have much lower ratings of the positive effects and seems to have much higher reports of the unwanted adverse effects. So it's not quite as an attractive as organic cannabis. It's also, as some people have said, comparatively expensive. Again, sorry, we're just leaping forward with the slides. The other thing that I think we need to be mindful of in relation to synthetic cannabinoids is the role of the public and media commentary. From other drugs, there has been evidence that media commentary can have an impact on consumption. So, for example, with solvent use, a number of studies demonstrated that when there was substantial media coverage of solvent use, that was actually associated with an increase in the number of people who were using solvents. And there's a couple of reports, for example, Stephen Bright and colleagues have reported that people first trying a new psychoactive substance, including but not restricted to synthetic cannabinoids, was associated with media commentary. So somebody uses a new psychoactive substance, somebody gets into trouble with it, the media commentate on it, and then there's an increase in the number of people who are seeking out these information about and purchase of these drugs online. And there's a lot of consumers actually say that the first time they heard about these drugs was through media reporting. That suggests not so much that we need a media ban, but it does suggest that we need to be carefully consider how we communicate information about synthetic cannabinoids and indeed other new psychoactive substances. The evidence in Australia suggests that the prevalence of synthetic cannabinoids is relatively low compared to other illicit drugs. I hesitate with that because, of course, people don't always put their hands up to say that they've used substances. But if we use some of the methodologies like the IDRS, like the National Drug Strategy Household Survey, it suggests that synthetic cannabinoid use in Australia is relatively low. We don't seem to have had the big increase in use that was experienced in some parts of Europe and some parts of the US. That may well be because of the legislation. It may well be because of the relative high price of synthetic cannabinoids. It may well be partly because people prefer, who choose to use cannabinoids, seem to prefer organic cannabis. But nevertheless, there still is a significant proportion of the population who do seem to get into difficulty with it. So a couple of important challenges for us. We need to know much more about the patterns of use, which is indicated by my hesitation on what we know about prevalence of use in Australia. And we need, obviously, to know much more about the risk. We can't rely just on online surveys or on a sample of 2 in a clinical case study. There's significant gaps in our knowledge about both prevalence and risk. And we also need to think very carefully about how we conduct the debate about new psychoactive substances, including synthetic cannabis, particularly in face of evidence, a small amount of evidence, but evidence that's consistent with what we know about other forms of drug use, that media commentary can increase consumer interest, at least in the short term, of relatively low prevalence drugs. So where from here? We need to know much more about prevalence patterns and contexts of use. For example, we don't know much about the impact of use on workplace behavior. We have very limited information about the impact on driving. We can make assumptions. We can look at the small number of studies that we have, but we need much more investment in research that answers the questions about prevalence, patterns, and context of use. We know that we need to know much more about the challenges of marketing and distribution. What I mean by that is the online marketing and distribution of a number of these products, the distribution through outlets in Australia that were not traditionally associated with the sale of illicit substances or recreational drugs. And we need to know much more about the short and long-term harms that can arise, both the individual risk from only using synthetic cannabinoids, remembering that there are scores of different synthetic cannabinoids, which is going to complicate issues, that many of the products that are on the market have a variety of substances in them which can change from time to time. And we also know very little about the drug interactions that may occur between synthetic cannabinoids, amphetamine, alcohol, and so on. But we do, where we have concerns of public health and individual health and safety, we also need to explore and develop much more effective interventions. So that means a better understanding of the distribution of the information about the product and the distribution of the product itself. We need to explore the range of regulatory and law enforcement responses that might have an impact on the prevalence of use and the sorts of harms, at the same time avoiding any increase in harms that can arise from that. And given the way in which the products appeared on the market and then changed rapidly in response to legislative change, we need to have speedy, not necessarily severe, but speedy responses, and that's consistent with the European Monitoring Centre on Drugs of Dependence and Addiction. And we need to explore more effective prevention and treatment options. One of the things we need to recognize is that at least some of the people who used synthetic cannabinoids lived in different contexts from some of the people that we might come across in relation to cannabis use and cannabis-related harms. So we need to have much better ways of engaging with, getting people in need into treatment and retaining them in treatment whilst delivering effective interventions. So that's essentially the end of my presentation. I guess now is an opportunity for people to ask questions.